for after this. So I'm on the panel today to talk about MOGAD treatments, and I'm happy to take any questions, but maybe we could start off by if I ask people to put up their hand and if they let me know which treatment they're currently taking, just so we get an idea of what sort of treatments people are on. So is there anybody in the audience on IVIG as a treatment? Okay, good number, okay. What about rituximab or ocrelizumab? Ocrevus, not so many. Subcutaneous immunoglobulin, there's a few here, okay. Tocilizumab, it's one of Actemra is the other one, yeah. I see some people on that one, okay. Or mycophenolate, Cellcept. Okay, we see some, okay, yeah. Or azathioprine, Imuran. Steroids, anybody on prednisone? Probably many people have been on prednisone, but some still on prednisone, okay. Any other medications I am forgetting? Okay. Well, yeah. Let us know what questions do people have about their treatments. We think about treatments as acute treatments, so that's your steroids, your plasma exchange or Plex treatment, and then our maintenance treatments. The only other thing, I'll mention is people on a clinical trial, because there may be some people who are involved in the clinical trials. Yes, so we have some here for. There's two trials currently at Mayo, is the rosnilimab, which we'll hear about, and the satralizumab. So questions people have? Yes, Julie.
This might be for a lot of people. Well, maybe I should use that. This might be something on a lot of people's minds, but it's been sort of suggested to me. I'm on a lifetime of subcutaneous IG likely, but in doing well for many years, there's some talk about maybe coming off of that. And, for somebody like me, I have a persistent titer of like 1 to 100 on that. And it's never any different. Maybe every once in a while it goes low, but not really that often. So if people were, have that kind of consistent titer, would anyone ever consider taking them off of their preventative medication in the future, even as they age?
Yeah, I think it's a good question. Some of the medications have less risk, like subcutaneous immunoglobulin does not really lower your immune system much. It doesn't have many long-term risks. Some of the oral medications like mycophenolate, azathioprine, if you use them for 10, 20 years, they do have risks of complications. You can have skin cancers and different types of tumors. So there can be some challenges with using the medication, some risks. And so you have to kind of weigh up those in addition, or people who are developing infections. It's difficult when the MOG antibody is still positive. The risk of relapse is higher, but some patients just maintain the MOG antibody for a long time and they don't relapse. So there was one study looking at people who came off of medications, and I think about 1/5 to 1/4 of those patients did relapse within a few years, but they tended to recover well from those relapses and not get additional disability. And it tended to be the patients who were persistently positive or who had had prior relapses who went on to have further relapses. So some of the things I consider when we're deciding about how long we'll be on the medication is how severe was the relapse, how many attacks have patients had, how have they recovered from each of the attacks, and what sort of side effects have they had. So there are some patients that I know that I would never be comfortable taking off medication, while there's others that maybe we would give it a try. And Dr. Chen has the steroid in the pocket, which many people might be involved in the study, where you bring home that steroids with you, and then if you were to have a relapse on a Friday evening, it's hard to get to the doctor, you could take the steroids quickly. And we would hope that that would be kind of a rescue mechanism for people that we did take off medication who may still be at risk. So it's kind of but I think more studies need to be done on that kind of stopping of medication. But we've only known about MOG, the test was only available at Mayo Clinic since 2017. So it'll take a while before we can get to that kind of level to have certainty there. Other questions? Yeah. There's Sylvie.
So the titer's always been kind of, I guess, almost irrelevant. So So like, say your teeter is like a 110 or a 99 or whatever it is. Like, is there anything that shows now that it's changed, or are you guys getting closer to finding something out that if your teeter is a 50, that doesn't matter? Because at first you're like, it doesn't matter if it's a 200, you have it, or if it's a 10, you have it.
Yeah.
If it's in there, and you guys would say pretty much whether it's a 10 or a 50, you have it.
Yeah.
Regardless. So, and medication doesn't matter. It doesn't. Is there a medication out there that shows that if you take it, like say I'm on IVIG and say my teeter is a 110 and another medication makes it a 100, does that change at all?
Yeah, there is. It's a great point. So initially we used the MOG antibody test to make the diagnosis, and once you're positive and you have all those features, then you can meet the diagnosis whether you're a low titer or sky high titer. Over time, if your level remains very, very high, then there does seem to be an increased risk of relapse. So some studies have looked at 6 and 12 months. If you maintain a very high level, then your risk of relapse is higher. But it doesn't mean it's 100%. So some of those patients will still not have relapses, and then some patients who go low or disappear will go on to have relapses. So I think we mostly make our decisions based on how many attacks patients are having, and the thing about the antibody levels is that there can be some variability in the lab. So if a sample comes in one day, we test it and it might be 1 in 100. The next day it's 1 in 40, because we kind of go 1 in 20, 1 in 40, 1 in 100, 1 in 1,000. So even small differences can change the titer. So we more base our decisions on how people are doing, how were their attacks, how many attacks they're having, and then we decide. But I think the titers may be useful. We've been collecting titers since 2019 on all of our patients, and we're trying to analyze that data right now to find out what the levels do and what the risk is, but we haven't kind of got all the analysis together. So hopefully in the next year or so we'll have some more information there too. But great question. Yes. Yes, next question. Go ahead.
Hi, I'm asking on behalf of my 15-year-old son who's had MOG diagnosed in 2020. And I just want to understand better the long-term risks of IVIG. So we did two-year stints of IVIG where he did really well, no relapses. As soon as he came off, relapse. And now we've moved on to tocilizumab. You can say it better than I can. So I'm just wondering, what reason might there be, I mean, I know what I've been told, to switch to a different medication after this IVIG treatment was working so well?
Yeah, so the challenges with IVIG can sometimes be it can be hard to tolerate. So sometimes people find that they get headaches, they get something called aseptic meningitis, where the meninges inflame, and can get fevers and chills and not tolerate the infusions. Sometimes if you space out the infusion, that goes better, but some people who take it even for over the course of 8 hours, they can still get a lot of those symptoms. In some of those situations, we switch to subcutaneous immunoglobulin. The IVIG in the long term doesn't really have much risk. It's quite an expensive medication, and sometimes the insurance companies will not allow it. So they may cut it off from us because it's quite expensive, and there has been some shortages in IVIG, so sometimes that can be a challenge. But it doesn't actually lower your immune system. If anything, it kind of boosts your immune system. There can be a bit of an increased risk of developing clots with IVIG. So sometimes that's a reason if people have had clots, well, we'll take them off of the IVIG and move to something else. And then other medications like tocilizumab, which blocks the interleukin-6, which is a signaling molecule, seems to work well, but it does lower the immune system a little bit. So we have to be careful if patients start to get ongoing infections. But the good news is some of these medications have been tried with other diseases. So we have long-term experience from, for example, NMO. There was some interleukin-6 blocker similar to tocilizumab, and the long-term safety data looks really good. So most of these medications are very safe to be on, even in the medium term. So I think, it is important to treat the disease, and if people have lost vision or have developed disability, these medications can be helpful. But I do think also that the clinical trials are really going to give us a lot of data, because right now some of these other studies that we base it off is just based on what we call retrospective data, which is not controlled, not matched. But in the clinical trials, things are organized very well in the placebo group and a treatment group. So this will give us really great information on if a medication really truly works, and then what its side effects are. We can monitor them much more closely. So I think going into the future, those clinical trials are going to be really crucial. And I think if people have the opportunity to be involved in trials or interested in trials, they're going to be serving really the MOG community for many decades to come, because if these medications work, then we'll be so thankful for all of those patients who enrolled in those clinical trials. Yes.
Hi there. So I'm currently on the COSMOG clinical trial.
Yes.
So this is something that's in my mind, but not a current issue. But for young women and women thinking of family planning, what are some of the timelines and for thinking of, what kind of treatment plan you're going to be on if you're thinking of, family planning, or while you're, pregnant or things like that? What is some of the, best treatment plans to be on for that scenario?
Yeah, it's a great question, and MOG affects many young women, and it's important to think about that. I think for many of the medications, we would have to come off the medication. There would be not proven safety in pregnancy, particularly mycophenolate or Cellcept is known to cause problems for the baby. There is some data that suggests a medication like IVIG or subcutaneous immunoglobulin may be safe in pregnancy. So that is an option that we've sometimes used in patients who are very active, or if patients have just had very few relapses, a milder case, we may stop the medication, let them try become pregnant, and then consider restarting a medication after they give birth. Some of the medications in multiple sclerosis and in NMOSD, some of the medications have a very long effect, like rituximab, and those patients who are on that, if you give a dose a month before they try to become pregnant, it can sometimes cover the patients for up to a year or a year and a half. So sometimes with those medications that can cover through pregnancy, but those B-cell medications don't work quite as well in MOG as they do in the other conditions. I suspect that they do work, but maybe just not quite as well. So we don't usually use those as our first choice. So probably our first choice would be immunoglobulins, either IVIG or subcutaneous immunoglobulins. So I think for the newer clinical trial medications, I know we've had some patients who were considering coming to trial and then they became pregnant, and we don't want people to become pregnant on these new medications to make sure that there's no harm to the baby. Yeah. Yes. Question.
Hi there. Are you aware of any treatments that either help somebody with neuropsychiatric symptoms along with MOG, or hurt them? Like, are there treatments that make it worse? My son's on steroids right now because he just had his attack, and it's making his symptoms so much worse. Yeah. So we're trying to go down lower, but they're suggesting rituximab next, and I'm not hearing anybody else doing that, but yeah. I think it could help his neuropsych. So I'm just wondering what your thoughts are.
Oh, it's a great point and great question. And for the neuropsychiatric symptoms, steroids are challenging because steroids can cause depression, anxiety, even suicidal ideation in some people. So they can also cause confusion in elderly people. So we have to be quite careful with our steroid dosing. And sometimes we even have to bring a patient into the hospital to give them steroids safely. And then we might have to get them off quicker to do that. The other medications don't tend to have as much of an impact. So rituximab, IVIG, tocilizumab, the new clinical trial medications, we haven't really seen a signal for those neuropsychiatric features. Now, it is important for people who have concomitant depression, anxiety, that's managed either with a therapist or with medications. So we do often work closely with our psychologists, and even with Dr. Basso, who mentioned earlier, when they do that neuropsychological testing, they'll often do questionnaires looking for those neuropsychiatric deficits, and that will often trigger us to involve our psychiatrists and see if we can help with those aspects. So I do think it's an important component to consider in trying to get off of the steroids quickly. But the steroids work well. I think everyone in the audience will probably say that the high doses work really well to dampen down the inflammation, but then maybe trying to get off it quickly and get onto some other medication would be helpful. Yeah.
Thank you.
Great. Yes, online questions?
Yes, we do have some online.
Okay. Or do you want to go ahead, Andrea?
Hello, Andrea Mitchell again. You're probably getting tired of my questions. Are there any studies that show that tocilizumab can cause a relapse?
I am not aware of any studies suggesting that tocilizumab would trigger a relapse. It's actually sometimes been used in the setting of very severe attacks. So we've heard earlier from some people about very severe attacks where they end up in the ICU in a coma, they might need a ventilator. And some of those children, there's been some studies suggesting that if you give the tocilizumab in that setting, it can actually help recover a situation that's really dangerous where the pressure is rising. So there have been some studies actually showing that can be quite helpful, but I'm not aware of any studies showing it trigger a relapse. There is for rituximab, it's a medication that kills your B cells, and sometimes antibodies will leak out of those B cells, and there's some suggestion that there can be a slight increased risk. So while the medications take effect, we sometimes will use a short course of steroids to try and cover them while the medication is taking effect, but I'm not aware of it provoking relapses. But maybe
Thank you for that answer, because my neurologist believed that.
Okay.
Yeah. All right. So we have a couple, I think we have 4 questions from online. The first one's from Marjorie. What treatments can we use to help pain, or what's recommended for pain associated with MOGAD?
Yeah, pain is common in MOG, particularly pain around the eye and headache. Sometimes patients will have concomitant migraine, and in that situation we can use migraine-specific medications to do that. There's acute migraine medications called triptans, and CGRP antagonists is new medications available for migraine. Otherwise, some of the nerve pain medications that we use, medications you'll be aware of like gabapentin or Neurontin, pregabalin or Lyrica. They usually take a while to titrate up, so we have to it'll take 6 to 8 weeks before we can see a full effect. Duloxetine or Cymbalta is another medication that we use for neuropathic pain. So we have a variety of options. I think, though, it can be challenging. Even with those treatments, we may not get complete control of the pain, so they may just take the edge off the pain. So we usually warn people that we may not be able to fully get that. The other thing to mention is that some people, if they have pain that's localized to the feet, for example, there are topical agents, numbing agents that you can use, or capsaicin cream, and some of those can be quite helpful and don't have the side effects of the oral medications.
Next question is, and we discussed what the options for preventive medication are, but this Shakina asked, is it recommended to be on preventative medication if you've never had a relapse?
Yeah, this is kind of the holy grail of a lot of what we're trying to learn about is we know that up to 50% of people who have their first attack of MOG will never have another attack. So we don't want to put them on long-term treatment that would expose some risk if they're destined never to have another relapse. So in general, at the current time, if somebody has an attack and recovers well, back to normal, we often don't start them on a long-term medication, and we will sometimes put them on a steroid wean for 4 to 6 weeks, and then we would observe and see if they have a second relapse. On the other hand, if you have just one attack, but it was very severe, you were in the ICU, it was life-threatening, or if you have an attack and you don't recover well, then those patients sometimes will err on the side of caution, and we'll put them on a medication straight off the bat.
What would you recommend if someone failed IVIG and had a relapse through it?
Yeah, I would say in that situation, if there was a clinical trial open for these new medications, I would consider enrolling in the clinical trial. Or we've had some success with tocilizumab or IL-6 blockers. So that's one that we often go to in the setting of a relapse on IVIG. But if that didn't work, then maybe the medications like rituximab we talked about, mycophenolate. So there's a few other options. Yeah.
And then our last question for this session is, this is an interesting one too. What's the current treatment standard for the rare slice of people who have the combination of MOG and MS?
Yes, good question. So I think the first thing to say, there is some suggestion out there of a MOG-MS overlap, but we have to be a little bit careful because it's mostly the MS patients who are tested. Patients with demyelinating disease, which includes many with MS, are tested for MOG, and some of those will have low MOG positive that are false positive. So you really want to try to tease out, is it MS or is it MOGAD? And if you can tease that out, then I would direct the treatment in those directions. For the very rare patients where it's difficult to be certain, I think the medications that target B cells, so that's your rituximab, ocrelizumab, might be a reasonable option because it covers across the two specialties. But in most of the times, it's going to be either one or the other. So I think it's important to try and tease that apart. Yeah. Okay. Julie, is that enough time? So we're at time, yeah? Okay, well, thank you all for your time. One more. Okay, one more. Yeah? One more.
Thanks. I've been on IVIG for coming up on 2 years now, and so I've just now heard about the under the skin.
Yep.
So I was curious as about, what you consider on being on the IVIG versus the whatever it's called.
Yeah.
And then you just mentioned with the question over there about if you had a relapse on IVIG, you would automatically switch, or if I've been on it for 2 years and I had a relapse, would you just say, okay, we'll stay on it? Or what would go into that consideration?
Yeah,
so those two questions.
Yeah, great question. So the IVIG versus the subcutaneous immunoglobulin, there are certain factors, for some individuals, if they have vision loss and they don't have somebody at home to help inject them, the IVIG can be easier because they find it hard to self-administer, or if they have some disability in their hands or those kind of things. So that can come into it. If they tolerate the IVIG well and it's covered by insurance and the infusion therapy center is not far away, or they can get it at home, then IVIG maybe just works perfectly fine. Sometimes when you try to switch, if you're on IVIG and you try to switch to the subcutaneous, then the insurance company says no, and they say we won't because it can be slightly more expensive. So sometimes insurance can come into it, or if you have IVIG covered by insurance, you might not want to risk trying to switch because then they might question when you try to go back. So there are some factors there that come into it, but particularly for people with infusion reactions or risk of clotting is a little bit less with the subcutaneous, so that might be an easier. And I think Dr. Chen is going to be looking at maybe potentially doing a clinical trial of subcutaneous immunoglobulin, so we might get some more data down the line in terms of how well that works. So for the second question, I do think if you have a definite relapse on a medication, then you might want to consider switching. Some patients have been through many different medications, and maybe we could accept a relapse, but most of the time we would probably try and consider switching to something else. But it may be that if you were on IVIG in a low dose, that we might increase your dose. We usually recommend about more than 1 gram per kilogram more than once a month. And if you're on lower doses than that, sometimes you can be at risk of a relapse. So sometimes we'll adjust the dosing or make it more frequent rather than switch to medication. But if you're at a good dose and you have a relapse, then probably you need to consider switching to something else. Yeah. And again, if there's a clinical trial available in the region, that can be also an option for people. Yeah. Great. Okay. Well, thanks very much. Next session we have 15-minute break now. So we're on a 15-minute break. So thanks everyone for listening, and we're getting towards the end. So thanks for all your patience and durability and this. Thanks.